This one's on.
Is there a switch I have to turn? Okay, hello. Hi, everyone. And I'm so happy to be the chair of this and not one of the panellists. Lee talked to me and said, would you like to talk about medication? And I go, I'm a GP, I prescribe all this medication and often it's really challenging and I'd much rather just ask these experts some questions. So we're going to be talking about that today. Just by way of introduction, I'm a GP who was the RAC GP representative on the Equally Well Alliance from the beginning, so they're probably looking to replace me, I'm sure, sometime soon, but I'm hanging on because I love it. It's the thing I love the most. And what we'll do is, starting with Lauren, if you could all just introduce yourself briefly, then we'll get you to start talking about this interesting topic.
I don't think my microphone... Thank you, thanks, Ricky. Hi, everyone. I'm Lauren. I'm a peer support worker working at Nimai National.
Hi, I'm Vicky Langan and I'm Health Promotion Manager for Nimai National, New South Wales.
Hi, I'm Amanda Wheeler. I'm Professor of Mental Health at Griffith University, working mostly in a research role.
And I'm Rod McKay and I'm a psychiatrist. Main area is working with older people, but also education and training.
Wonderful. Okay, it's good to have some educators and mental health researchers, peer workers, it's fantastic. So maybe we'll start with Lauren, if you want to make some opening statements about this topic, and I'll give everyone a chance to make 3 or 4 points, and then we'll go into some questions, and then there'll be a chance for you all to ask questions too.
Sure. I fixed the microphone. Took it apart. All right. So I've tried to summarise it into 3 key points. I figured that I would share some stories because as a lived experience worker, that's my specialty. And that's how I sort of make my points today. So the first one is, the overarching point is the importance that needs to be paid to comorbidities and being really, really careful in what we do and taking in the bigger picture, particularly as we prescribe new medication and monitor these symptoms. The story that I have for you is when the first time I ever went to a psychiatrist and I was diagnosed immediately with ADHD. That's what I went there to be assessed for. It makes sense. But what was missed were some other serious mental health issues, and the medication that I was prescribed, the stimulant medication, sent me into my first psychotic episode, my first manic episode. Sorry. So that being missed and being prescribed something that was incorrect for me had dire consequences. We can look at the symptoms of medication on the surface level and we can see these symptoms, in appetite, sleep, things like that. But when we're just looking for that, we miss the bigger picture and we miss the consequences of those symptoms. And these consequences can have long, long-lasting implications for someone's life. So we're playing with really big stuff here. And if me working with a psychiatrist at the time, not having a whole treating team, I was kind of at the mercy of that psychiatrist and their judgment. They sort of saw me come in, made a quick assessment and quick judgment, and with that made errors that could have had really disastrous consequences. Well, it did have disastrous consequences, but luckily I made it through. Luckily I'm here today. So that's sort of my first story about being careful and monitoring for symptoms. Oh, and in that, I'll go back a little. I really want to draw attention to the fact that when people access this medication, they're left alone with these side effects and these symptoms. I didn't have anywhere to go for answers. I called the psychiatrist's office and said, I'm having a little bit of paranoia, bit of anxiety, and was told, oh, the psychiatrist isn't available at the moment, so, maybe just take a little bit less of the medication. That should be right. When I came back into him and said, oh, I'm having this psychosis and this is what's going on, I became so anxious that I couldn't even speak. He said, well, you should have stopped taking the medication. It would have been really good to know, but that wasn't communicated to me at the time because we're just left alone, sort of flapping around, trying to do our best, trying to make sense of what's happening to us. So that's my first story. The second story is to draw attention to the importance of communication. So communication with consumers and communication with the wider care team. So the second story I'll share is about when I was prescribed antipsychotics. And a little side effect that happened was that I completely lost my vision. As I tapered up in the medication, one day sort of things became really blurry. Then the next day, really blurry. And the day after that, I really couldn't see clearly at all. I thought I didn't know what was going on. I thought maybe I'd had an aneurysm or something, or it really wasn't explained to me at all. As is the experience for a lot of people, we walk out of the psychiatrist's office with our script, here's your medication, off you go. This is why most of us, I think, get on Google, which is not the best place to go. We get on TikTok, we get on all of these all these apps to try to make sense of things, and they're not the most reputable sources, as we know. So I lost my vision and I called a nurse hotline because luckily I knew that there was some sort of help out there. And then I went to an optometrist, and it was explained to me by the optometrist that antipsychotics can have this side effect. Complete surprise to me, complete news. So I called the psychiatrist's office. He was not available, of course, and I wouldn't have been able to afford an appointment anyway. And was just told to stop taking the medication. So once again, stop taking the medication. So again, who was accountable there? What was the treatment plan? What were we trying to treat? What could happen? I didn't know. That informed consent really wasn't there. And you might be thinking, well, those were some pretty bad psychiatrists. They didn't follow the ethical guidelines. This is clear to me. But these stories that I'm sharing are so common. This is, I think, really the norm. This is what I see from so many people, from my consumers, from my friends, everyone. Third story is over the other page. The third story was from last week, a different psychiatrist. I've had a few. They all have different diagnosis, by the way, of course. So last week I go in for my medication review, and I did flag with my psychiatrist that perhaps I'm heading into a hypomanic episode. I symptom track every day. I know myself fairly well. And he said, no, you couldn't be going into that. If you were, you wouldn't have been able to wait in the waiting room for an hour. Okay. I said, sure. Because he is the expert and we don't argue with the expert. And if I was to argue, then I might not get the treatment that I want, the effective treatment. So, I just say that's fine. Never does he, didn't ask about my appetite, my sleep, or the fact that I was up the night before writing poetry at 2 a.m. with my thoughts absolutely racing. So luckily I know myself, I work in mental health, I have access to this information. But anyway, so I tell that story to kind of draw attention to the importance of person-centred care, remembering that people are the experts on themselves. And we want to work in consultation with our treatment team and our psychiatrists and draw on their expertise. But high functioning is not the same as functioning, and my ability to present well in a psychiatrist's office is just that. It's just evidence of my ability to mask my neurodivergent, to present well, as I've done in spaces, and as I'm doing right now, which, yeah. So those are my key stories, and sort of to summarise, my points were, number one, we need to be so careful, and we can do that really well when psychiatrists and GPs are working with a treatment team, not just drawing on their, one sort of individual interaction with someone, because sometimes these interactions are 15 minutes, an hour. You can't know someone in that time. Second point is to communicate clearly and to co-collaborate with clients and with consumers, so that they're really informed, they have the information, they know what their treatment plan is and what the future of that looks like. And then the third point is about person-centred care, paying really careful attention to what they're saying, what people really feel, not just what they're sort of coming in and presenting with according to a textbook. It's so much deeper than that. Thank you. Thank you so much, everyone. I'm really grateful to be here today.
Thank you, Lauren, for sharing that. And there's some very true things that ring true, I think, from lots of stories I've heard as well. So we'll come back to you in a moment, but I'll let Vicky speak now.
Okay. I suppose that feeds into the work that we have done in relation to addressing the support around medication for our consumers. So I'm going to talk from the point of view of an organisation, a community mental health organisation, NEMI National, who are primarily non-clinical. And as a direct result of funding requirements, we moved to develop a guideline for our staff and for our consumers around having conversations about medication. Because the funding requirement was that we move to medication compliance with our consumers as part of our job. And this is in outreach services with non-clinical staff. So we did do a survey of staff responses to that and what that would look like, and it was very diverse. A lot of people believed, no, it's not my role, I'm not qualified to do that, and of course not. Our staff are not clinicians. However, we had to come up with, I suppose, a way of working with our funding body in order to secure the funding. And we set upon putting together and I will say, a very well done co-design process of creating the Conversations About Medication guideline. One of the key points that came up I suppose straight up, was that our consumers were telling us, and still to this day tell us, they're not being heard by their clinicians, and that they wanted NEMI support services to support them and advocate alongside them around their medication prescribing. So we went, as I said, we went forward and created that guideline. I suppose one of the things that has stuck out for me talking around this was one of those things was that power. So it was mentioned by Richard Osborne actually yesterday around giving away power is an issue for clinicians. And this is something that we felt, or that the consumers were very clear in saying absolutely, that when they go in to have their medication review, that they feel they don't have really a choice or a voice in that. But what was also happening was that NEMI staff who were going along to support them in that and advocate alongside them were also feeling that power imbalance and not being respected or accepted as a valid support person. So can you imagine how the consumer was feeling? So look, we worked together with the consumers, and we came up together. We came up with 4 areas that they believed, we all believed, that was necessary to put into this guideline for people to move forward in being able to properly advocate around their medication. And in this guideline, the 4 areas were: 1, education. And we talk about educating our staff on very basic information, and also educating our consumers. They want to know what type of medication they're being prescribed, and don't just assume that they won't know. This is a big thing of this assumptions being made. And so we want to educate our staff and our consumers. But also so that they have an opportunity to make those decisions around those type of medications. I suppose one of the other things, was just as I said, improving that health literacy side of things. So the second area then that we focused on was something that one of our lived experience workers came up with, was area of concordance. And when we talk of concordance, it's actually a dynamic where the consumer and the clinician reach an agreement together on the plan around their medication. So we took a concordance approach, and that's what we were encouraging our consumers to sit down with the clinicians to do. And NEMI would support that process. And the other area then was adherence, that we would support them in adhering to that plan that was made during a concordance meeting. And I suppose the final area then was duty of care, and it's our responsibility to ensure that everybody is safe. And just during the survey that we did with staff, believe it or not, when we talk about health literacy, a vast majority of staff came back when I asked what was their idea of adherence and what was their idea of compliance. A lot of staff came back and said, what's the difference? Aren't they the same thing? So look how important it is when our staff don't know what it is, and we're talking to our consumers and just assuming that they know. So that education, the concordance approach, supporting adherence and duty of care. Thank you.
Thanks, Vicky. It's really helpful to hear those views of someone trying to do something in this area. It also links back, I guess, to what Lauren was saying about, there's misdiagnoses, there's wrong diagnoses, there's also evolving diagnoses and evolving treatments. And I guess that also fits with the idea of concordance, because, everybody being on the same page about what it might be rather than what it definitely is a challenge, isn't it? I'll now let Amanda give her main points.
Thanks, Caroline. Just a bit more context about me. So before I moved into academia, I worked for 20 years in New Zealand and the UK, basically in secondary care settings as a mental health pharmacist. So I have worked in a number of settings. I worked with forensic services, hospital inpatient environments, and for most of the time in community teams where I did a lot of liaison work between general practice, specialist mental health and community pharmacy, with really one of the main focuses was trying to look at the safe and effective use of antipsychotics, but particularly with clozapine. And so that's really where I'm kind of speaking from, I suppose, today. And I'm also an Equally Well ambassador, primarily around pharmacy practice and medication, I suppose. Thanks, as Russell pointed out this morning. So I guess I've also got 3 main points. I think 3 main points is the flavour today. Really thinking about medication and managing medication-related problems like side effects. So I think Lauren and Vicky have both touched on them in different ways, but sort of bringing it back to, I suppose, from a pharmacy perspective. So thinking about, or a clinical perspective, first of all, shared decision making. So that's the concordance plan. So, medication needs to be really individualised. So no one's going to respond the same way, no one's going to have exactly the same experience on medication, and yet we want to make medication. I think medication for most people is, do I really need to have medication? And it's an acceptance process we all have to go through for whatever we might need to take medication for. So we want to make sure we have information to make a decision, and we want to have time to look at it. We want to have time to discuss it with people, peer workers, our family, and try and make as much an informed decision as we possibly can, and that's going to involve the prescriber and people as well. So coming up with a plan, so it's not that just prescribing, it's about the plan, how are we going to monitor it, what kind of things might I expect to happen to me, what are the risks and benefits of the choice of medications I actually have to make this decision about. So I can't underplay the importance of that time to make that decision and to have the information and to really discuss it, to be as informed as possible. And we might still get it wrong and we might still have a negative experience, but hopefully we've got monitoring and a plan in place so that it can be stopped quickly and go down another pathway. So that was the first thing, I think. The second thing was the importance of communication, which you also both alluded to reduce medication-related problems and harm. People experiencing mental health issues and side effects and then obviously many times physical health issues as well, are often seeing a multitude of clinicians and prescribers. So, and consequently, they then have complex medication regimes. So if all those people involved in that process don't talk to one another, don't communicate that information, if the psychiatrist doesn't know what the GP's been prescribing and vice versa, and then the person who's in the middle of all of this is the consumer and their family and their support people. So they're the constant there, and so we need to make sure that communication of information is constant and that we're all responsible for it. So every time we see someone, it's almost like just doing a check-in quickly for what they think they're taking at the moment, what medications they're taking, checking to see what they're being prescribed as well, and making sure if you change anything, that information is shared with everybody afterwards as well, because it just can get so confusing. And that's when we have medication errors and we have things that we don't want to happen, negative experiences. I think the third thing sort of follows along from that is the need for regular medication review. We've talked about evolving symptoms, we've talked about evolving side effects, more medications get added, we experience different side effects, different treatment burden, and we need to bring it back and we need to do medication review regularly. So I think also utilising the funded services that are available in community pharmacy and that pharmacists can actually provide as well. So a meds check that can be done on a 12-monthly basis for people who it's done in the pharmacy. They can do a medication review, and it's just about checking in with people as how they're taking their medicines, about understanding what they're for, understanding what side effects they might experience and that kind of thing. And then if there are problems, there's also the possibility of having a home medicines review. So a pharmacist, again, on a sort of 12-monthly basis can actually undertake a home medicines review and actually spend much more time with someone. It doesn't have to be in their home, it can be an environment that both people agree on, but that's just the name of the actual review process. So, and a GP and a psychiatrist or any other specialist can refer someone for that service if they think the person's experiencing medication-related problems. So I think they're underutilised services, particularly in mental health, and there's something we can pick up on. I think that was my points.
Thank you, Amanda. That's very helpful, and certainly I agree. As a GP, I can attest to the benefit of a good quality home medicine review. Often they're actually just telling me to do things I've already done, which is nice. You kind of go, oh, I've already checked their thyroid function and tick, tick, tick. But it can be helpful because sometimes there's interactions that a pharmacist knows about that as a GP I wouldn't be as familiar with, particularly when you're getting into complex regimes. Now, Rod, you're the psychiatrist in the group. You get to go last, so you have to add to these wonderful things. Please share your thoughts with us.
I'll start with, if you like, the easy part. I think the easy part is, yes, using medications well is a team endeavour. And there's different ways of making it a team endeavour. One right or wrong way of doing it, but it's really important to do it. And the issue of, I think, of not just whoever the prescriber is, whether it's a psychiatrist, whether it's a GP, or whether it's somebody else, is actually, I think actually it's incredibly difficult to actually help the consumer actually feel they can ask the question. And I think that's a really difficult dynamic, which the doctor often ends up in the wrong end of as well. I think both end up in the wrong end. And I'd point out, I think some of the work that the New South Wales Mental Health Commission did there, actually with consumers and with clinicians, about creating postcards to actually support the discussion, and the idea there are cues there about a discussion is okay, and it's okay to have that discussion, whether it's that, but actually the things that create an environment that encourage it are important, because lots of things get in the way of open communication, no matter what the desire is on both sides. I think another thing is that it is really important to not set and forget that even if something is going really well, things change. And as an old age psychiatrist, I get the privilege of seeing what happens when things go wrong and when things go right over a long time. And so side effects change with age or when different things happen. So does the effect of medication. But just because someone is doing really well for 10 years doesn't mean there shouldn't be regular review. And I think it's too easy just to let things keep on going. I think the harder discussion is, and the reason we have these discussions is, we need to also remember, though, that actually psychiatric medications do good as well as harm. And I think we can lose sight of that. And I think even as psychiatrists, we can start to question, well, yeah, where is the balance? And it's been a lot of work looking at that in the last 5 years. And actually the results, particularly looking at people who've got diagnosis of schizophrenia and on antipsychotics, are striking and opposite of what the investigators expected. That actually a marked reduction in death for people with schizophrenia on regular antipsychotics. A really marked reduction. And so we need to remember that therefore we know there's all the side effects, we know we have to do better, but we do have to do better because actually they're doing something really important. And so I think we've got to keep that context when we're having our discussions. And I'll come back to a story. And it's a consumer story, but it's the impact it had on me, because it was a video that I was shown from a consumer advocate who'd been given the video to share, not share publicly, but share with individuals. And what it was an older person who had a diagnosis of schizophrenia, who was in palliative care, and who was pleading to be allowed to die sane. The other side of the concern about medications is taking them off without being clear actually why the person is on them in the first place, and discussing with the person about actually what's the value of the medication for them, or when they get older and they may not be able to tell you for a variety of reasons, to go back and find out. So I think part of good medication use is also knowing when to continue as well as to reduce or to cease.
Yes, thank you. I've certainly counselled many young GPs who have made that mistake of saying, you look really well, I'm just going to stop these medications, and without actually taking the time to talk to other, family members and other people and getting a little bit of longitudinal history. So that's a very mindful reminder. So maybe, Lauren, I'll come back to you and I'll call for you for questions, so start thinking. But I guess as I was listening to all that, it sounds like there are strategies that, there's a language around concordance, there's postcards, there's ways of professionals to communicate. Thinking from your experience or from other people you've spoken to, what are some of the ones that are most likely to put you in a position where you can get the information you need? Is it the conversation, or is it a resource? Or is it a mixture of things? I mean, what do you think would be the most useful if we had to put our energy somewhere?
Question. Lots of questions, but not always the answers. What would be useful? I suppose, yes, it's always good to have visuals, and it is good to walk out. I'm someone who, really struggles with memory, so I make lots of notes while I'm in there and walk out. Something I've developed, I suppose, through trial and error and realising where the gap was. But not everyone has that. So perhaps if it were part of regular practice that, people do walk out with resources and something in their hands. What about, ensuring that consumers do understand what their medication is treating, what the suspected diagnoses are, what the potential risks are, through that literally being signed, some regulation there, some psychiatrists really being held accountable. And I'm sure that they are, and I know that they're doing the best that they can. But with these, errors that happened with me and that happen with so many people I know, like, how are they happening and why is that still the norm? So I don't have all the answers, but that's some of my thoughts.
That's very helpful, and I think it also comes back to how good are clinicians at communicating uncertainty. It takes a bit of courage as a clinician to be able to say to a patient, I don't know. I found it's gotten easier as I've gone on in my career, because you don't know because you really don't know, as opposed to because you're incompetent. So that is helpful to think about the things, and so that then comes to this question about how much information, because I'm pretty sure I was certainly taught, and I think this is a question probably for Rod and Amanda, this notion of, well, if you tell people everything you could tell them about a medication, they'd never take it. And particularly for someone who's on a treatment order, that's maybe not a good idea because then they won't take it. How do you deal or they might, my situation, someone's very anxious and you don't want to make them more anxious. In general practice, we do a thing called safety netting, where we say, I don't think this will happen to you, but here are 3 things that you need to tell me if they do happen. How do you guys deal with that tension between giving people enough information to make an informed choice, but not so much information that you actually make them more worried and maybe not take a medication that they actually need to take, perhaps? Or you can comment too, Vicky.
Just jumping quickly on that, it's sometimes asking them how much information do they want to know.
The unknown unknowns, but yes.
Yeah. I think it's about trying to assess what the point the person's at and actually what they can even take in at that point in time. So it might be, it's always just checking in, like, what kind of information would you like, when do you want it, and what format do you want it in? It comes back to the number of conversations we've had in the last 2 days about literacy as well, is about making sure that there's a match for the person, working with, asking about having a support person. I think most of us, again, it comes back to what would we want to know? If we put ourselves in those shoes all the time, if this was me sitting there, what would I want to know? How would I want to know it? So would I want someone with me? Yes, most likely. If this is about a big decision I've got to make about starting a medication, I'm going to go out of here and forget half of the information. I need someone with me. So I think, and then making sure we have got access to resources for people that match all those different levels. So some that's visual, some that's got minimum information when it's just an overview of medications, perhaps for a certain illness. Then it might be more specific if you were going to have to make a decision about particular ones. And I think, and coming back to your point about the risks and benefits are really important. You want to give people information, and you want to not just highlight all the bad things that might happen to someone. You do need to talk about, well, what are the benefits? Why? What should we expect this medication or this treatment to actually do? What are some of the ways you're going to be able to see whether it's actually working? But I think that's a problem with medications that we often are using for physical health problems for people who are on antipsychotics and mood stabilisers and things. We're using them for prevention. And so stopping, you actually don't really notice necessarily that you're actually taking them, except for side effects, because you don't see that it's actually helping your blood cholesterol or something like that. So it's difficult, and more medications we end up taking, it's just, I think people just feel like they feel like they rattle, So being aware of that.
Thank you. I think that's certainly been my experience as a GP when my patients come back, and the solution is always another tablet, not one less, usually another one on top of, and it is quite challenging, isn't it, when you get that medication burden. So I don't know, Rod, do you have some views on that, or maybe also some strategies you use to reduce the side effects?
I agree. First of all, I think the key question is asking what the person wants to know. I've normally got a very short list of things I think a person must know. If I'm prescribing antipsychotic for someone who's got dementia, I will discuss stroke risk. Just won't prescribe it without doing that. Whether it's with the person, if it's early, or whether it's with the carer. Interesting enough, though, open discussion, I've never had someone say they wouldn't take it after having that discussion. So I think we need to be open to having the discussions. But then it normally is, I think, 2 things. It is actually asking the person what else they'd like to know, or do they want to know more? I can go through a long list, or I do encourage them to read and come back next time and let's have the discussion next time, because they all will anyway. And I think that's when the most important discussion is often the second one rather than the first one. It's just as an important discussion, though, reducing the medication. And I've had to also learn that it's acceptable for someone to say, no, I don't want to reduce the medication, that actually I do prefer the side effects than the risk. And that took me a long time of actually working with someone for about 12 months, trying to convince them to reduce their medication because it was just unsafe. But they were happy that it was unsafe because the benefits for them after 20 years of being unwell were they just did not want to touch it. And it took me a long while to accept that, but that was a really important lesson for me. So both ways, I think it's about the discussion, but often I think the second visit is important. And yes, I don't know. I rarely say, I can guarantee this is going to do this. I discuss, this is what I hope it's going to do. Both ways, for good and bad.
So it's a bit of a balancing act. We need a balance. Vicky, did you want to add something?
Yeah, I think one of the really important things, and I suppose a strategy that our staff support service users to put together strategies to be able to adhere to their medication. So when they do get their plan, okay, how the hell am I going to manage this? Often, like myself, I forget to take a vitamin in the morning, you go home and it's still there 2 days later, you go, oh, that was Wednesday's vitamin and today's Sunday. So it's about supporting that process for each individual, and each individual will be different. But one of the most important things, and I think for clinicians, is that sense of caring and connectiveness with the person that they're treating. And I just want to reflect on something that somebody said to me today, who has been at a Equally Well conference previously and is now at this one. And it's a lot of the same people, but they've said to me, wow, it's really different this year. All the people that are the keynote speakers that are presenting are much more humanized than they were before. Isn't that beautiful? In that they're actually able to make a connection. And I think that's so important when, being a treating clinician. So that's one of the, I suppose, for us as a community mental health organisation, coming from a recovery-orientated approach, or what we are, I suppose, our model of practice is collaborative relational practice. That's what we do, and it's very important.
Yeah, thank you. Rod?
Another thing I encourage the psychiatry trainees to do, but I'd encourage everybody to do, is there's an article, which I'm almost certain is open access, by Pat Deegan, who actually writes about her journey of medication use. And it's really, really valuable. It's very short, but it's her story of her journey and the goods and the bads of it, but the need to be on that journey. And I think that idea that actually medication use is a journey and you've got to work with the person on that journey is a really important concept. And what's good for them at one stage may not be good later, and vice versa.
Yep, and that's where the Health Talk website comes in as well. Very good place to go to get information about people's experience of taking various medications. So let's move, in the last 10 minutes or so, let's move to some questions from the room. There's someone up there. Can someone got the mic to run around? There's... Oh, okay. Yes, can you monitor that and let me know? Yep. So there's someone up the back and then there. So one here and then you're second. This lady here, thanks. Oh, that'd be lovely to have some help. Thank you. Thanks, John. Thank you, John.
Is that on? Yeah. Yeah, my concern comes from being a mother of a child who takes medications. He's 17 and he has to go from his paediatrician to a psychiatrist. Now, he does not want to have another doctor or anyone knowing about his conditions and what medications he's on, but we're basically being forced to see a psychiatrist because the paediatrician can't take his medication and his GP is not allowed to prescribe the medication that he takes. So what option do carers, parents, children have through that lifespan of taking medication and growing up? So, the last day and today, I've heard about shared care plans. How does that actually work for like a 17-year-old who's trying to get these medications that are working for him? He doesn't want to change, but he can't find a psychiatrist because there's such a huge wait list for psychiatrists. I'm from Canberra. And he feels really comfortable with his paediatrician, but yeah, she can't continue that care.
Yeah, that's a very important question. It's the transition of care for young people with complex illness in any field is very tricky. Same for people with cystic fibrosis, a lot of those groups. Does someone have an answer to that problem? Because it is a tricky one, that transition from child-based care to adult-based care.
It's not just child to adult, it's also adult to see when people move or move into residential care. Transitions are really hard. It doesn't solve it, doesn't give you an answer now, but I really think the key thing is they will happen. And I actually think it needs planning a year or two ahead now, if you possibly can, because I think that is the timelines that can be required. And we need to be talking about that planning.
On a brighter note, I have had some paediatricians in my area who have seen some of my patients up until the age of 20 to exactly deal with that problem. Now up the back.
Yeah, g'day, Rod. Yeah. One of the things I used to do when I was working as a peer worker was going back to Patricia Deegan. She wrote a leaflet, and it was called Regaining Power in Medication Conversations with Your Doctor. And it gave strategies that the consumers could use to take in, written down, to go in and see their doctor to talk about medication. It was a fabulous tool. It's out there somewhere. I've just got to find it.
Thank you. If you can find it, please do share it with the Equally Well crew. Michael.
Yeah, I'll talk like a manic chipmunk just to get through this. What Gwen just said, 20 years in a mental health service as an advocate, I used to give the consumers questions to ask your doctor. We've had them for years. And people that don't use them, I wonder why they don't. You sit down and you go through them with them, and it's that prior preparation prevents something poor performance thing. And so that when they go in there, even the doctor can understand it. Sorry, Rod. And the other thing I encourage them to do too is keep track of their medication over a period of a month, breakfast, lunch and dinner, and how they were feeling, so that even a doctor can see what's wrong when they look at it, instead of trying to come up with something that the doctor doesn't think you know what you're talking about because you're going, I think about 2 weeks ago this. The other thing I wanted to talk about was the thing that really cheesed me off and got me passionate with the side effects years ago, when we used to use the LUNZES tool, the University Neuroleptic Side Effects Rating Scale tool, to reduce the side effects. Was when my daughter had a side effect from taking an antipsychotic and it nearly killed her. So I sat around at a clinical governance committee asking every doctor and clinician in there, tell me if there's any side effects she needs to look out for. I work here now, so I'm going to look after her. She's going to get better treatment. Bullshit, that didn't happen. She rang me up one day and said, Dad, I'm getting a tingling tongue. By the time I got down to her, she was twisted up on the footpath, swollen neck, and nearly choking to death. And I can't even remember getting her to the emergency department. And they obviously, you know what I'm going to say, they stuck a cogentin drip in her arm and 10 minutes later she was back to normal. My point was, all I wanted to know, and what you should tell the consumer, is what's the terrible side effects and what's the early warning signs of those side effects. And if you don't do that, then you're negligent, in my book. And it happens far too often and it's still happening and it needs to stop happening. And I've retired from the mental health service now, Rob, but I haven't stopped from speaking up for consumers, and especially that one. If there's bad side effects, you know, dystonia, that swelling up and all that other stuff you get from one of the side effects, well then you should tell the consumer to watch out for that. That's not putting it in their head, making them imagine it. That's giving them an early warning sign to something that could possibly kill them.
Yeah, thank you, Michael. And it's also a very important reminder about the benefit of family knowing you're on medication. That's a difficult conversation I have in general practice when people don't want anyone else to know they're on medication. And I say sometimes an ally can help you to watch for some of those things and be with you on that journey, which is something like you've described as an experience. But not everybody wants that to be shared, sometimes because they get stigmatising views from family members, which can be challenging. There was a question here now.
I'd like to ask everybody how they're, or whether or not they're excited about the upcoming and broader knowledge about pharmacogenomics and testing, especially in the psychosocial medication regimes.
Fantastic question. Individualised prescribing. Is it on the horizon? It's been promised for so long, hasn't it? Who wants to comment?
I'm excited if we can actually get it to work. I'm not yet convinced that we've got it in a stage that it actually is a useful tool for most people. There are exceptions and it's fantastic when the exceptions are there, but I think we've got a long way to go. Great thing to hope for.
Well, I've been involved in it with Professor Wu, and although it didn't actually help me with the medication journey that I went on, because I'm actually reacting really badly to everything that was green lighted. But at least it gave a better starting point than just, this is cheaper, we'll chuck her on that first. And if it doesn't kill her, all well and good. But 5 medications later, I was getting a little bit desperate to not be put in a dangerous situation, especially as the 4th, 5th and 6th medication, I was no longer inpatient and not being supervised. So, but it is, I think, a very wonderful tool, especially if we have more gene sets in the studies, and so that they have even more comprehensive knowledge about how medications work or don't work for certain people.
Yeah, wonderful. And I think that's certainly the way I see it being used now, is for people who have tried many medications. It does have a role in giving more information, doesn't it? I'm looking forward to the day that we as GPs can also do it, but we're not quite there, you know, because it's yet not cost effective to do it at a large scale for everybody. But I agree, it doesn't make sense if it can help to not give it to people. That's a good idea. Now, we're only going to take 2 more questions. So this lady in the front and then that lady, and then we'll have to draw it to a close.
Hi, I'm from a regional area and we have a really hard time finding a GP and finding a GP who will talk about medication reduction or coming off medication is impossible, because they refer to psychiatrists as being the experts on that decision making. And if the psychiatrists in the area are unaffordable, what can we do to reduce the effects of the antipsychotics on our physical health?
I don't have an answer to that complex question. I mean, certainly I'm aware that the RNZCP has been given funding to create a diploma of psychiatry specifically to train GPs in areas of great need to step in as a role substitution for some of that. But that's going to be a long time coming to address that concern. And I think there's a few things we need, but more consultation liaison models where the GP can phone and speak to a psychiatrist and get advice and do it, which is really what Amanda was talking about, rather than having to send someone off somewhere else. I think a lot more of that could be done in a consultation liaison way, but we don't have the systems yet to properly fund that or to support it.
The only other thing I was going to add is that a lot of the research we've been doing recently is working with GPs and community pharmacists in regional and remote areas, and actually get the two working really closely together. So sometimes the delay in getting to see a GP was very difficult, but then the community pharmacy was picking up some of the monitoring and support work when someone had been started on a new medicine or were transferring medicines and things like that. So again, it's about working as a team and using the resources that are available in that regional area.
And I think the other thing is, I mean, because Hetty's run a course, was designed initially specifically for GPs, and the difficulty is once they become more involved, they actually start losing money in their practice quite quickly. So effectively, it's a multi-pronged problem which doesn't help you now. I think there's an awareness, but there's lots of things that need to change.
That one and one more.
Yeah, just a quick question. So I work as an exercise physiologist in the NDIS sector and work with a lot of complex psychosocial disabilities. And I've had a lot of clients that I work with who are really resistant to start psych medications because of weight gain. And it might seem trivial, but it is honestly the biggest barrier that people tell me about. They say, I don't want to gain weight by going on this medication. And so they go through these significant mental health concerns because they're resistant to take the medication. I operate from a very much health at every size approach, and I want to know how we can facilitate more of a health at every size approach from the wider clinical community and from GPs and psychiatrists and psychologists to make sure people are actually getting the most important benefits out of their medications.
Someone like to respond to that? Do you have a thought, Lauren or Vicky? Do you have any?
You reminded me of the exact same question that I came up against, the exact same fear when I was prescribed antipsychotics. one thing I knew about them was that they make people gain weight. And I thought, is it better to be skinny and crazy, were the words I was using, or fat and sane? Terrible words to use, and I had to make that decision. And that's what I see in the consumers that I work with now, struggling with that. It's a very good question.
It's important. First of all, it's a real problem, but it is different for different medications. And I think so. So the other thing is, I think it's important to be able to have an informed discussion around what the options are. And the other thing in terms of starting medication, you can start the conversation with what are the side effects that most concern you, and that can influence what's prescribed. So I think that conversation about what's important is another part, and encouraging people to go in prepared for that conversation.
So I'm sorry we're eating into the break, but I think we can manage it. Last one.
Thanks for that opportunity. Amanda, hi, my name is Arani. I had the joy of going to a 4-day conference last year on psychosis in Perugia, Italy, and there was a talk, one Dutch pharmacist and doctor that had started doing tapering with the antipsychotic medication, so going down by 0.1 milligrams. So instead of going from 10 to 7.5, 7.5, 5, 2.5, which often has the consequences it has. I just wondered if you've heard of any pharmacists in Australia now doing that, because he was actually offering to send the scripts to Holland and then they would make it up for you there. But, I don't know, probably breaks the law. But it'd be great if that could be done here, because like my son, we went from 7.5 to 5 and boom, back we are in, where. And whereas if you went down, what they've found with the studies is you go down 7.5, 7.4, 7.3, 7.2, and you find that perfect spot.
Yeah, it's
like a lower dose spot.
going low and slow, going up and doing the same, and reverse when someone's starting and doing the same when someone's stopping. Sometimes people can, again, it's individualised. Some people can stop and actually have no problems. Other people try stopping and it's terrible. Others go slowly over a week. It's so individualised, and I think it's then about working with, once you know if that's how you tend to respond, then it's about flagging it and saying, look, even if I'm not this time, I don't know, but I'd really like to go slow and I want to go as slow as possible, and then trying to work with a pharmacy to actually, they can use or give you a tablet cutter, and you can end up breaking a tablet into, tiny amounts, and it's just about taking it down as slow as you can manage. You don't want to have to go through making solutions and things up to do it, but it's, sometimes you can take it down to every second day if medicines have got a long half-life, and so they actually work across more than 24 hours. There's lots of ways of managing it, but it's trying to work with the person to find the best way of doing it to stop. Sorry? No. The main way would be to actually have them all cut up into small parts as you possibly can.
Okay, I'm getting the wind up, guys. So I'm going to say thank you, everyone, for coming and for this wonderful conversation.
People online they've mainly just supported Lauren's comments. So just so you know that you've got a lot of support for those things.
Thank you.
So thank you, everybody. We're going to take a break. We're coming back at 3:20. Then we're going to have the inaugural Mental Health Equally Well Awards. So look forward to that, especially if you're a nominee. Thanks, everybody.